Hello and welcome. I'm Rita Cullen. I'm the Athena Swan champion for the Institute of Health and Wellbeing, and I'm really pleased to see so many of you joining us here today for this research talk, which has been organised to mark International Women's Day. So I'm absolutely delighted that we are joined by Abby Fraser, who's going to tell us about her research work in this area, and she'll be speaking to the topic Women's Health and Ageing Cohort Datasets, Insights from the UK Biobank. So if I could just remind everybody to keep your microphone on mute during the presentation, and we'll hold our questions until the end. We think there'll probably be about 15 to 20 minutes available for questions and discussion at the end. So Abby, if you're ready, I'll pass over to you now.
Fantastic, thank you very much. I was just doing some quick edits on the title slide because I realised I hadn't changed the title from the last one, but that's all changed now for consistency. So I will share my screen. Obligatory, if you can see it, please let me know. Is that all good? Excellent. I will take that as a yes. So yes, thank you very much everyone for joining me for this presentation that I was really keen to give, especially around International Women's Day. My name's Abby Fraser. I am about a month away from submitting my PhD. And my PhD has been studying variation in menopause experience from a public health perspective. So one of the main focuses of my research, even if it wasn't particularly my main focus coming into the research project, has been looking at the ways in which women's health is approached in public health. And I think that in the current context, where we see an awful lot of recent increase in public attention surrounding women's health, and in particularly the deficit of research and knowledge that there is in women's health, that's coming out very strongly in public health, that there are quite a few things that I have learned during my research project that I think are quite valuable to communicate to other people in the health sciences. So that's what I would like to use this presentation for. It's going to be a little bit theoretical. It's going to be a little bit based on my personal experiences of research. And at the end, I'm going to give my recommendations for how we in public health should be moving the direction of research into women's health towards. So, as I was saying, the context for this talk, the sort of the immediate context with International Women's Day having been on Tuesday. Yes, sorry, I was getting my dates mixed up. And also the fact that there have recently been two quite big calls from both the Scottish Government and the UK Government, calls for evidence and the formation of plans around a women's health strategy and a women's health agenda. And if anyone has been involved in these calls, you will know that it has been a very wide request for information. It's not just any specific aspect of women's health that has been requested. It has been all aspects of women's health, sort of going from the menstrual cycle, menarche, puberty, sexual health and pregnancy, up towards menopause and even non-reproductive health outcomes in women. So it's quite encouraging that there is this sudden interest. I was going to say renewed, but I don't think it was ever there in the first place, but there's certainly this increasing interest in approaching and tackling issues related to women's health on a governmental level within the UK. So traditionally, public health's interest in women's health has not extended to this very comprehensive overview that is being requested of scientists by the government. And the interest has previously very much related strictly to reproduction and pathologies of the reproductive organs. So that is saying that there was a particular focus in public health surrounding pregnancy and infant mortality and infant health and maternal mortality, And then thinking about the public health approaches that we have to cervical cancer screening, to breast cancer screening. These are all very much related to reproduction specifically and pathologies of the reproductive tract. And now we're seeing this change where these sex and gender-based differences in health and disease are now becoming salient research questions in public health, where there is a demand, certainly from a governmental level, to be able to produce the knowledge that is needed to structure healthcare services, preventative healthcare policies in order to address these needs. And I do want to just clarify at the beginning here that issues around women's health both relate to the female sex and also the gender identity of being a woman. So I know that they are both not the same thing, and I want to make that specification clear here. At the moment, I will largely be talking about the influence of the female biological sex on health. I'm just making that distinction clear at the beginning. So the fact that there has been this new interest in women's health certainly indicates to the fact that there has previously been a very big deficit in what we know about women's health and how do we approach women's health from a public health perspective. And this absence of knowledge, interest, care about women's health does not exist in a vacuum. It doesn't just happen to be as it was. And this is where I'm really calling for renewed interest in understanding the systems of knowledge production, which have perpetuated this systematic exclusion of women's health research from the public health agenda. And it goes beyond the public health agenda. It really incorporates the entirety of biomedicine. And when I say biomedicine, what I mean is the dominant way in which we view questions of health and disease, particularly in the contemporary Western context. And biomedicine is really just what we intuitively know as health and disease at the moment. But it's particularly important to know that the way that we generate all of our knowledge about health and disease through a biomedical approach means that knowledge is bounded by an awful lot of conceptual limitations. And these conceptual limitations are what influence the focus of research. What do we do research on? And it also relates to how we view health and disease ourselves. What is considered healthy and what is considered a disease? And therefore, what do we then want to do research into, or what do we feel like we need to do research into? And in the next couple of slides, what I'm going to explain is how I have found that these limitations have themselves a tangible impact on how research into women's health has been shaped previously and continues to be done. So a quick overview. I know some of you might have heard me talking about this already. I do like to incorporate this into an awful lot of my presentations, but that's just because I find it so salient to the topic when I'm talking about it. So what I'm going to be talking about here is trying to understand where our current approaches towards women's health have originated in biomedicine. And we think about biomedicine itself as this system of making sense of health and disease. We can locate the origins of biomedicine amongst Western European medical scientists, sort of at the end of the 1600s, the 1700s, coming into 1800s, around the time of the Enlightenment. And this is when we are seeing also huge increases being made in the fields of physics and chemistry and biology, you know, the discovery of sort of the laws of physics. And what happened with biomedicine is that the discovery of these natural laws in other disciplines, scientists were wanting to emulate that with the body. So they were wanting to find sort of the equivalent of the Newton's first and second and third laws of health, of physics to do with health. And this has very much shaped the way in which we think about health from this biomedical perspective. And again, you're going to listen to what I'm saying to you, and you're going to think that this is incredibly intuitive. Like, I'm just explaining things that we all know, like we all know how it works already. But because it's so deeply ingrained in how we approach health and disease, that's where I argue that these conceptual limitations that are preventing women's health from being studied are originating from. So if we think about what is health, well, health is when nothing is wrong with you. Therefore, a disease is what happens when there is something that's wrong with you. So if you are healthy and then you contract the disease, then the goal of medicine is to remedy that disease through an intervention to return the person back to a normal, healthy state. And that's, you know, so much of our medical system revolves around this central tenet. But this is where we start to bring in the idea of, well, what is normal? What is this normal, healthy state that we are all striving towards? Sorry, I realised there was a pop-up on the screen. I do apologise. What is this normal, healthy state that we are all striving towards attaining? What are we basing this state on? And as with many things in history, the early practitioners of biomedicine were predominantly white, upper-class males from European populations. And this is where our idea of the healthy body has really stemmed from. And the philosopher Canguilhem makes the distinction between healthy and not healthy quite clear in his statement that pathology is a deviation from the norm. So where does women's health fit in this? Well, women's health is affected by these conceptual limitations in biomedicine in two major ways. So first of all is the inherent pathologization of the female reproductive cycle, the menstrual cycle. If we think about the difference between the male body and taking the male body as this sort of the upstanding healthy body, then the main difference between the male body and the female body is the menstrual cycle. It is a constant deviation from this normal functioning of the male body that's being exhibited in females. And that deviation becomes pathological in the biomedical definition of health. Second of all, the pathologization of the reproductive tract. Therefore, through all of the ways in which knowledge is produced in the biomedical setting, we have to control for confounders, have to find this natural law that is uninhibited by any confounding factors. And applying that logic there means that there is rationale for menstrual cycles, the reproductive cycle, to be controlled for in medical studies. And one of the things that has become very prominent over, say, the past 5 years is this awareness that at every step of the biomedical knowledge production, particularly in to do with pharmaceuticals, this is one of the major areas where this is common practice in clinical trials, was the systematic exclusion of females from the test population. And it happens not even in the late stage trials of drugs, it happens at a cellular level. It happens in the selection of cells and model organisms where the treatments are being tested. It is at all stages of the biomedical clinical process. And what this means is that we now have this assumption that on all levels apart from the female reproductive tract, the male body and the female body are the same. And that the female body is the male body, but just with something else added onto it. That's just operating in the background, bleeding every month, you know, sometimes pops out a couple of babies. Apart from that, there's very little influence over female health. And one of the major things I want you to take away from this talk is that we really have to challenge this approach. We have to challenge these assumptions that are perpetuated and co-produced throughout all of the processes of health research, because we know that that's not really true. So what I want to challenge against is, first of all, against this compartmentalization. And again, this is something that you're going to think is so innate to the way that we understand health and disease, but I want to lay it bare so that you become aware that it's structured this way for a specific reason. The body is very seldom viewed as an entire unit. If we think about the way that health is practiced, we think about the way that medicine is practiced, all of the different systems of the body are separated down, relating to their various organs, their various systems. We've got the immune system, the cardiovascular system, the reproductive system. We look at dermatology, we look at the brain. Everything is compartmentalized within the body. Yes, it makes it much easier to study. But what it also does is it removes the opportunity to really focus on the interaction between these different systems in the body. Because speaking as a person, I do like to think of myself as whole, and that I'm not just a bunch of different systems working within the same biological space. As humans, we are much greater than the sum of our parts. And this is something that I think is especially pertinent when we're looking at the interaction between the reproductive system and non-reproductive health in the context of female health. And it's something that is recognized anecdotally all the time, maybe just if not academically. And there are several disciplines where this approach very much goes against compartmentalization. So for example, systems biology and evolutionary biology, all of the tenets here are that the body, all of the different systems of the body are interacting, and that in that interaction itself must be the origin of different components of health and disease. And then second of all, what I want to challenge is against this pathologization of the menstrual cycle and therefore female sex. Female sex is not a deviant of the male body. They exist as two separate entities. And the menstrual cycle is a fundamental component of the female biological sex. Again, it's not operating just in the background. This diagram here that I have on the right is just a snippet from my qualitative research where I have been documenting the breadth of menopause symptoms that have been experienced by participants in my research study. And the reason why I've put this in here is because all of these different symptoms have been documented throughout my research relating to menopause. And if we were to think about this very compartmentalized view of the reproductive system, we would think that only the reproductive system would then be influenced by something like menopause, the cessation of the reproductive cycle. But what we have here is people talking about mental side effects, cognitive side effects. They're talking about neurological side effects of the immune system, side effects of the gastrointestinal system. There are so many, and this would probably be called anecdotal evidence, or certainly it would only be viewed within the context of qualitative evidence, but it indicates that there is an interaction that occurs between the reproductive cycle and non-reproductive health. And the issue of this pathologization really comes to the forefront when we're looking at questions of actual conditions of the reproductive system. If all periods are inherently pathologized, then how do we go about studying cases like endometriosis and polycystic ovarian syndrome and premenstrual dysphoric disorder? My apologies, I'm not massive on what that abbreviation is. That seems to change. But what we have here is what would be, in many cases, very debilitating conditions relating to the reproductive cycle. But because the reproductive cycle itself is something that is sort of inherently disposed to go wrong, they just don't get studied, or they get studied in much less detail than they require. And the other thing about this very stiff conceptualization of the normal function being healthy is that the body's function inherently varies across the lifespan. The body at birth is very different to the body of old age. And this variation is inherent. It happens as we grow up. So how do we incorporate that variation in the menstrual cycle across the lifespan if, again, the menstrual cycle is inherently pathologized itself? So this is a bit of the background that I'm talking about, the ways in which women's health is conceptualized. And in my next part of the talk, I'm going to talk about how I have found this to have been present in my research. So a little bit of context here about the actual research project I was doing. So my overall thesis question was understanding how do ecological factors shape variation in menopause experience. And as a mixed methods project, I had a qualitative component, which was where that diagram came from, and a quantitative component, because I wanted to use epidemiology and quantitative methods in a way that would allow me to understand how does timing in menopause vary across populations. Does it vary? As quite a standard epidemiological question. And then starting to think about, well, what are the determinants of this variation in age at menopause? The mean age of menopause in the UK is currently 51. Or it's considered to be 51, and generally from what I found is that it will range from between 46 to 58. That's the sort of range we're working with here. So my specific research question here was going to be researching the relationship between the female reproductive system and age of menopause. And I was conducting this research project with the UK Biobank. For those that are unfamiliar, the UK Biobank is a large aging cohort dataset, which is based out of Oxford. It has about 500,000 participants. So because I was only looking at the female population, that was a sample size of about 250,000. And it very much considers itself to be a comprehensive repository of variables relating to all different aspects of health. So they have got imaging data, they have got genotype data, they have got biomarker data, and questionnaire data, which was what I was working with here. So the main reason why I use UK Biobank, apart from the fact that it's very highly renowned, it's sort of the gold standard really of aging cohort studies, is because it was one, if the only aging cohort study in the UK that included data on age at menopause. So even though menopause is a fundamental component of the female aging process, it was the only study that I could find, the only cohort that I could find that collected data on age at menopause. So I was kind of stuck with it. But at the beginning, I thought, well, this is fantastic because it's such a good data set. Everybody uses it. There's so much public health research that's based upon this data set. I hope that this can really bring some credibility to my research here, because menopause is probably one of the most understudied facets of even women's aging. So if I could bring some credibility to my research project, make people say, oh, well, she got that result from Biobank, then that could really alleviate the way in which my research would be considered. So for this specific aspect of my research project, my variables of interest were age at menopause, naturally, with age at menopause here being the age at which the menstrual cycle ceases in women. And I was also interested in reproductive life history variables. And the reason why I was wanting to do this is because I wanted to have a look at the reproductive system sort of on a whole, rather than the different components on it. It's not new. This has been conducted in studies previously, the calculation of lifetime menstrual activity and lifetime menstrual cycles. And essentially, it's just trying to estimate how many menstrual cycles, how many periods has a participant had, and is there a relationship between that and, well, my outcome was age at menopause. So pretty uncomplicated. I wasn't going to do any massive statistical analysis on it. I was hoping it was going to be quite a standard research project. So on this slide here, and because I don't want to go too much into my research project, but I just want to visualize for you two of the main issues that I came up against. So the first is that I found that in this aging cohort dataset, the measurement of menopause as a component of the female aging process was hugely variable across the cohort. And that variation was very much originating from the age of the participants. So biobank participants, recruited participants who were born between 1936 and 1970. And the initial stage of the data collection was completed between 2006 and 2011. So on the assumption that the mean age at menopause was 51, then I was really expecting there to be quite good data collected for age at menopause for everyone that was sort of born before 1960, because they would have reached 51 by the time they would have had their first initial assessment where this data was collected. And this figure here on the left is just a bog standard KM plot, which is showing the age at menopause, when age at menopause has been recorded amongst this cohort, stratified by birth cohorts of about 5 years. So there is a massive distinction here between the older members of the cohort and the younger members of the cohort. In fact, the response rate drops, by about 30% between those who were born in 1951 to 55 and those who were born in 1956. And for my research project, what that meant for me is that I then had to exclude half of the population. But it also started me thinking about, well, why on earth is there this massive cohort effect for even the response rates for this question? And one of the main things that I can think of was the fact that menopause, even though it's being collected as a variable here that is a point in time, it's a year. What year did you finish your periods? The actual experience of menopause is a process. And it's characterized by the dysregulation of the menstrual cycle. So the menstrual cycle that is considered to be, pretty standard 28 days, becomes dysregulated. So periods become longer, menstrual cycles become shorter. You can go for months without a period, and then you'll have another one. That's just typical of menopause as it is experienced. And what that does is that adds an extra layer of difficulty in asking a participant who may very well be in the perimenopause, in the menopausal transition, to say, well, have you had your final menstrual period? They very well could have, but because it's been so dysregulated, they might say, well, I feel like maybe I might have another one in me. And that initially introduces a huge aspect of uncertainty to the collection of age at menopause as a variable. And what I think we're seeing here with this massive disparity between the reporting of age at menopause, massive disparity within one variable, is the fact that that uncertainty is just not allowed to be captured by Biobank the way that they were doing it. I hope this is making sense. If you want to ask any more questions about this, then please feel free to ask at the end. So this was one of the major limitations for my research project, and it stemmed from my variable of interest. And the second one was, unfortunately, the other side of my question, which was, what's the relationship between the reproductive life history and age at menopause? So as I said beforehand, Biobank, it says on its in its catalogue of variables, it very proudly says we collect data on female reproductive life history, on female health. It's there, we collect it. We have made a conscious effort to do this. So I came into this research project thinking, well, fantastic. They're measuring all of these different variables that I would need to be able to calculate lifetime menstrual activity. But then when you have a look at the variables that are actually present, which are on the left-hand column of the table that's on the right, which was a very complicated way of explaining something that you can just see on the screen. The variables that are present in the UK Biobank, sure, they do cover different aspects of reproductive life history. They've got age at menarche, they've got parity, they've got data on contraceptive usage. But when you actually look into it from the perspective of wanting to understand female reproductive life history, there are also an awful lot of variables that are absent. So one of the key variables, and it's something, again, that is collected, that is studied in other epidemiological studies, is menstrual cycle length. And the decision that was made with Biobank is that they're only going to ask what your menstrual cycle length was at the time of the assessment if you're not menopausal, which, if you're considering that a considerable proportion of the younger members of the cohort are probably perimenopausal and experiencing dysregulation of their menstrual cycle, then an awful lot of those responses just come back as irregular. Another inconsistency that I found was around parity. So they asked for parity, they asked number of miscarriages, stillbirths, terminations, age at first birth and age at last birth. However, there was no data that was collected on the age at each birth. So if you were wanting to do some sort of time to event analysis, then in between the first and the last birth, if they've had more than 3 babies, you're introducing an element of guessing there. Didn't ask about multiple births, and there was absolutely no data on breastfeeding at all, which I would argue is quite an important component of the female reproductive system, both experientially, but also from the fact that it has an intrinsic effect on the reproductive cycle. It's lactational amenorrhea suppresses the reproductive system. So if you have someone that is consistently breastfeeding, then their reproductive system is also not functioning. And then the other aspect was contraceptive usage. So they ask about age at first use contraceptives and age last use contraceptives. But there's no easily accessible data on the type of oral contraceptive that is used. And again, there's an awful lot of nuance that comes into that. There are an awful lot of assumptions in that, because the 2 different types of oral contraceptives, combined oral contraceptives and the progesterone-only oral contraceptives, interact with the reproductive system in 2 very different ways. And it's not great to conflate the 2, especially if you have the reproductive system as the focus of your research. There's also just very little easily accessible knowledge on long-acting reversible contraceptive usage. So, for example, the Mirena coil, the Depo-Provera injection, the implants. Sure, you might be able to get it from the pharmaceutical records that they hold, but good luck trying to navigate that as a PhD student with a limited amount of time and energy. And there's also no way to know about the starting and the stopping of contraceptive usage, because, again, if you think about contraceptive usage intuitively, you start when you're younger, and if you're using it as birth control, then when you're ready to have a baby, you'll stop using it. And it's not one specific time period that you will use oral contraceptives, particularly amongst perimenopausal women, is this connectivity between oral contraceptive usage, which then transitions into hormonal replacement therapy. So it does serve multiple purposes, and it's not something that you can really assume someone is using it for whatever purpose. And also people swap between methods as well in terms of finding one that works the best for them. So when I was presented with this, with the variables that we did have and the variables that we didn't have, in the end, I had to abandon the research project because I could have done something with it, but knowing what I knew about the reproductive system, and using this data set would have just incorporated too many limitations, and it would have just fundamentally undermined any of the results that I would have obtained from the analysis. And I think one of the other things that's very telling about this graph here is that there isn't really any consistency in what they are asking and what they're not asking. It's not as if they've got a massive conspiracy against breastfeeding or parity. It just kind of strikes me a little bit, and I apologise to UK Biobank, but it strikes me as just a little bit careless. But it's a carelessness which ultimately affected my ability to do a research project that everyone around me thought was pretty tangible. So enough about emoting all of my grievances with my quantitative analysis to you. I'll allow myself a little second of feeling sorry for myself. But what I really want to bring back from that presentation there, and to bring this back to the topic of the research presentation, which is the role of data sets in public health research into women's health, is that we really need to start thinking about data sets themselves as actants in the research process. So to draw from science and technology studies, actor network theory, it sounds complicated, but essentially it's just recognizing that inanimate objects can also have a considerable influence over the outcome of something. And this is where I really want to emphasize that I consider these data sets, which have ultimately been constructed under the biomedical lens, are affecting research into women's health considerably, significantly. And the cynic in me knows that there's someone that's going to listen to this and go, well, oh, you just didn't pick a data set that was suitable for the research question. And I really want to move this discussion away from the suitability of the data set, because ultimately there was no data set that was suitable for me. This was the only one that was available, and these were the limitations I encountered. And to not use Biobank would have meant I just wouldn't have done the research project in the first place. Where does that put us in the knowledge production around menopause that someone else is giving up on it? So I really want to emphasize that these limitations I've found, I consider to be emblematic of the biomedical framework under which UK Biobank was formed and functions under. And therefore, we need to stop approaching data sets and data as passive actors in the research process. You know, it's numbers that we do stuff with. But it extends beyond that. It's not inert. The data that we have is the outcome of a whole set of decision-making from those who are collecting the data. It shapes what the data was collected, what data was collected, when it was collected, how it was collected, was it collected in the first place? And this shapes the research, this availability shapes the research that can and cannot be conducted. You can't do research if you don't have data on it. You have to produce that data somewhere. And as I hopefully showed in the previous slide, there were two different ways in which I really saw that coming through in my research into menopause. The first was this poor capturing of the menopause variable by Biobank in the first place. And then it was the inconsistencies in what was available for the reproductive life history traits. So where does this leave using Biobank to study women's health, or just to study questions of health in general? It doesn't have to be women's health specifically. If we're wanting to really embrace the focus of sex-specific health characteristics, then the implications of this extend into studies of non-communicable diseases, into mental health, because the sex differences are there to be discovered. And I would say that UK Biobank and other data sets that have this fundamental biomedical framework underpinning them do not permit a considerable portion of sex-specific phenotypic features to be included in the study of women's health. Want to find out what the impact of breastfeeding is on COVID? Well, you can't with UK Biobank. Sorry, that was a bit pointed. I do apologise. But ultimately, it leaves us in women's health in this measurement trap, that the lack of information from research about women's health is both the cause and effect of the continuing ignorance of the subject. And as a last slide here, this is what I consider the consequences to be. Without considering the role of these data sets in research, how successful are we as public health going to be in addressing these renewed calls for research into women's health, if these are the resources that we have available to us? And there's a paper that came out this year which relates specifically to endometriosis, but as I was reading it, I was thinking there's so many parallels here with menopause, and I really could extend this paper. I could really extend what the author was saying, it was Hudson, saying to so many different aspects of women's health, which is that it's an undone science. And that the fact that there's a little evidence that's available and the consensus isn't great, that this limited evidence base and the lacking scientific consensus, the long-standing mis- and under-recognition of the condition, attempts to standardize treatment are built on an incomplete foundation in which one prioritizes objective knowledge. And it becomes a tautology of women's health being considered to be difficult or unable to be measured. And it becomes a self-fulfilling prophecy. If you assume that it can't be measured because you're using tools which do not measure it correctly, then what's the point? And this just, it's a bit of a strong statement, but I would argue that this justifies its systematic ignorance in the biomedical sciences. If it's something that's too difficult to do, then why would you do it? And why would you focus on it? So I feel like that got very depressing at the end, and I really hope in the questions we can maybe move towards thinking constructively about how we can research women's health in the future and how we can address all of these limitations, whether it be in Biobank and other quantitative data sets. If there are any experiences that anyone has had of, trying to study women's health, or even have succeeded in studying women's health, and I would love to hear it, because unfortunately at the end of my research project I just felt very disheartened, and this is one of the main reasons why I wanted to communicate this to other people, is that I think it's something that we should be discussing, especially in the context of women's health is all of a sudden becoming more sexy a subject to study. It could be something that could pull in grant money, could be very attractive, but we really have to think about how we're going to do it and the tools that we use to do it. So I just have some references here in case anyone found what I was talking about interesting, wants to read a little bit more on it. And I will stop sharing my screen, and I really look forward to the discussion that we will hopefully have. So I will stop sharing now. And thankfully, I don't think too many people have left. So I'm very happy to take questions.
Thank you so much, Abby, for that wonderful talk, which is, as you say, I can understand why you would be feeling a bit disheartened about this, but it's really thought-provoking and it's so valuable to bring these issues to our attention. I can see already in the chat that there are some comments and questions coming in. So the first question here in the chat is, have you looked at EHR as a potentially better source of data for your research, or is menopause not discussed or recorded enough in general? Is this not just an issue with cohort datasets?
No, that is a really good question, and it's certainly one of the avenues for menopause data specifically that I have seen people discussing. And I think I heard that there is actually a team over at Edinburgh that have secured funding to try and generate a menopause data set using electronic health records. The reason why I'm skeptical, and this is also coming back to, I have personal experience actually of working in a GP surgery. I have personal experience of seeing how the electronic health records look, how they exist, and how the information gets put on them and what information doesn't get put on them. And in my personal experience, if you're a woman that's going through menopause and you go to the doctor, what will be coded on, if anything does get coded on, will be, oh, well, are you wanting HRT treatment? Menopause itself doesn't tend to be something that is coded on. So a more reliable indicator I would suggest there would be HRT usage. But that introduces a huge amount of variability about, well, how does HRT relate to timing of menopause? Because the perimenopausal symptoms can emerge prior to final menstrual period. So in that way, if you are going to try and estimate timing of age of menopause and you're using HRT prescription, then you're making an awful lot of assumptions there. And again, there is this increasing overlap, and I really do think in the past 3 years, the guidelines around prescriptions and the prescription of hormonal contraception going into HRT are changing to accommodate this. But there's an awful lot of overlap between using oral contraceptives for their contraceptive purpose and then it being used in therapeutically as HRT. And one of the other aspects is, and this is coming from my qualitative research, is that it's not as easy as just booking an appointment, going to the GP saying, can I have some HRT? And then the GP saying, yes, here you go, here's some patches. HRT has, opinions on HRT have changed drastically over the past 30 years. It used to be very widely prescribed. I think it was a third of all women going through menopause in the UK prior to 2000 were on HRT. And then with the Women's Health Initiative and the Million Women study investigating this link between HRT usage and breast cancer, endometrial cancer, etc., the prescription guidelines changed drastically. And this is something which has not yet remedied. There's very little consistency amongst prescribing of HRT in GPs, particularly amongst the participants I spoke to. So using EHRs would be really interesting, but again, I think there are just too many limitations. They are specifically related to menopause for me to have any sort of faith in the data that they would be using or that they would be generating.
Thanks, Abby. The second question is, were you able to engage anyone centrally at UK Biobank and start a dialogue about why these gaps in data exist?
So at the moment, I've not. That is intuitively the next step, and it is something that I hope I don't burn too many bridges before I do that. And it's something that if Biobank were very happy and willing to, listen to my concerns, listening to my experience, then I would happily engage with them. Unfortunately, again, coming back to personal experience of trying to work with the Biobank, because I was the PI for my research project. I was the one who applied for the data. I was the one that interacted with the Biobank. I don't want to hold grudges, but it wasn't very inspiring. But again, if they're happy to listen, then I'm very happy to collaborate. And I have heard that it is possible to do this. One of my main concerns, however, with this is that another issue that I didn't talk about because it didn't really specifically relate to women's health, but that I think contributed to this, the poor reporting of menopause, is that the collection of imaging data, I think, has taken a huge precedence over the collecting of questionnaire data in the biobank. So much so that out of, I think there's 20 different assessment centres in the initial and the second wave of the questionnaire collection. But then the number of imaging centres was reduced down to 4 for the third and the fourth wave because they were imaging centres. And that has massively restricted the number of people who have then gone back for, to participate in the imaging studies, but then also that are able to answer the questionnaires presented there as well. And I think that that is also going to be a major factor, that there are clearly sort of priorities in terms of where Biobank are wanting to collect more data and where their focus is. They might not explicitly state it, but implicitly I think that it does exist.
Thanks, Abby. Yeah, I think that the constraints of having to go to an assessment centre are obviously going to have a big impact on the kinds of questions that can be asked. And I know that Biobank also have online waves of data collection, but those are not always, they don't always get a huge response rate either. And I think there's probably a limited number of opportunities that a Biobank would use to gather that kind of data as well. We have a question here in the chat asking, have you come across any such data sets in low or middle income countries?
Again, no, unfortunately, just based on my, it hasn't been an area that I've looked specifically into, just because I had established my research area very, very early on as just wanting to look at the UK. So I'm not aware of any research. I'm sorry, I spilled coffee on my top and it just sort of like knocked me out a little bit what I was thinking about. But I've not come across any data sets that I think would collect data on menopause in any greater detail than you would find in Biobank. Something that I found at the beginning of my research project is I looked at the global gateway to aging. I think it's a website that compiles and puts together a whole bunch of aging cohort data sets from around the world. Sorry, I forgot the word again there. And I was looking through, I think they have about 21 aging cohort data sets on there, and you could search for the questions. And I was searching through them and I found that out of the 21, there were only 5 that had any sort of questions to do with menopause. So again, that introduces an inherent issue if you're wanting to study menopause, timing menopause in lower middle income countries. It's that either you're going to have to go out and collect the data yourself, which is hugely time consuming, expensive, and I would say requires a level of seniority in academia that that not everybody has, or you're going to have to make do with what's available. So unfortunately, yes, again.
Thanks, Abby. So there's another question in the chat just asking if other psychosocial variables are collected as standard practice in the UK Biobank data sets that would be of relevance to other kinds of women's health research.
Oh, definitely. And that's a great question. And it also incorporates a little bit of the other side of my research question that I didn't touch on in this presentation, which was understanding the ecological context and the interactions between that and timing of menopause. But of course, it's incredibly prescient to other questions or other areas of women's health research. And unfortunately, to be very predictable, again, these sort of psychosocial variables, we had a look, we wanted to incorporate them into our analysis. I really don't think there were any on gender-based violence. There were some that were relating to early life exposure to abuse, So physical abuse, sexual abuse, did you feel loved by your parents? However, again, these were collected at a later stage of a later wave. So the response rate was minimal. It was maybe, I think, it was about 20,000 responses out of an initial population of 250,000. So unfortunately, I think that the psychosocial variables that people are coming to recognise are very salient. They are very useful for research into women's health, into a more ecological social determinants of health view, seem to be a little bit of an afterthought. And if they are collected, they get collected later, which unfortunately does not help with response rate.
Thanks, Abby. I think what I can maybe do, or if Abby, if you happen to have it handy, we could even put a link in the chat to the UK Biobank showcase so that people can see the other kinds of variables that that have been collected. There have been a number of different questionnaires, to the best of my knowledge, done at different times, and sometimes it takes a bit of digging to find out whether the thing you're interested in has actually been asked about at a certain point in time. Great. So does anybody have any further questions? I have one question myself, but I'd just like to give the opportunity if anybody has any further questions or comments that they'd like to put to Abby just now. Okay, I don't see anything else coming in the chat, and there aren't any hands up. My question, Abby, is you mentioned earlier about the way that age at menopause have been asked about in UK Biobank. So if you had a magic wand and you could have gone back and had them do that differently, and bearing in mind, obviously, that these questions have to be short and to the point, what could they have asked that would have given more informative data for you and for others who want to do the kind of research that you do?
No, that's an excellent question, and it's kind of the last chapter of my thesis is coming to this. Well, if I had the opportunity to design the data collection, what would I find useful? And also not just what would I find useful, but what do I think would relate very much to the experience of menopause. So this is where I thought that the fact that I did mixed methods and I have the qualitative portion of my thesis really gave additional insight. Because one of my first questions in the qualitative was, well, whereabouts are you in the menopause transition? And please define it for yourself. And what came out was the main determinants of timing of menopause. Yes, there was bleeding, but it was so much more on symptom experience. And also they would bring in whether or not they were doing anything to remedy that symptom experience, like therapeutic use of HRT or other things, which really cemented to me that in the actual lived experience of menopause, timing, unless you're experiencing a particularly early menopause, that was when it became quite significant. The timing, the difference between whether or not you had your final menstrual period when you were 51, when you were 53, when you were 49, didn't really matter to the participants. It was the symptoms themselves that were really the most important determinant of lived experience. And the thing is, I believe that it extends way beyond just the impact of symptoms, because obviously these symptoms are coming from somewhere. They're stemming from some physiological interaction between the dysregulation of the menstrual cycle and the other systems in the body. So I believe that documenting certainly when you started to feel symptoms could be a really useful data point, because we can then use that to think about, well, rather than viewing menopause as an event, let's think of it as a process, and perhaps that process begins with the emergence of symptoms. And that then gives something that is quite easy to incorporate. You know, it's like a time variable. When does it start? When does it stop? But I think even if we did that and included that in all of our research into menopause timing, sorry, I say all of our research, I mean the very minimal research that's been done into it, but it would bring I think an extra element to understanding the actual way in which menopause happens, which could hopefully translate into some very meaningful results.
Well, on that positive note, let's wrap it up there. And I want to thank you very much again, Abby, for that wonderful talk. And thanks to everybody for coming along and participating today. The recording will be shared on the IHW Teams page in the near future if you want to view again. Thank you, everybody. I'll stop the recording now.
Thank you, everyone.